Good afternoon, everyone. This is Dr. Mitch Rodriguez. I am filling in for Dr. James Curran today. He was unable to make the meeting. We'll go ahead and get the meeting started. The July 7th Department of Public Health Board meeting. I'd like to thank everyone for participating and joining us today. I'll start off with basically doing a roll call. We'll start off with Dr. Curran, who's absent. Myself, I'm present. Dr. Cheek.
Present.
Thank you. Dr. White. I see you're on, so we'll count you present. Dr. Mercer.
Present.
Thank you. Dr. Shin. Mr. Harper. Major General Carden. Okay. Based on our number of folks that are present on the board, we don't have a quorum at this point. We'll still go ahead and just go through the process of letting you know you did have the minutes, and we'll probably just have to send a request for approval. Unless there's any discussion on the minutes that were sent out, we'll just submit those for approval via email, if that's okay with the group. Okay. Fantastic. So we'll go ahead.
I think I missed the roll call. It's Dr. White.
Yeah, Dr. White, I did count you as present, so that you were on. So I did count you as present. Thank you for letting us know.
Thank you.
Okay, so we'll move on to new business, and we'll start off with the epidemiology update. I think Dr. Drenzek will be giving us the epidemiology update if she's on. We'll go first. Before we do that, we'll go on with the commissioner's report. Dr. Toomey.
Yeah, thanks so much. You'll see that some of us are not present in person here because we have had a number of people testing positive, and I think you'll hear in Dr. Drenzek's report, that although our numbers are not particularly high, we do have an increase in community spread based on the fact that the Omicron B5 is highly contagious, and many people are using home tests. And so that I'm sure she's going to talk more about that. But before I do, I want to congratulate those of you who've been reappointed to the board. I'm so grateful to you for your commitment to public health. Dr. Curran, who's not here, but who was reappointed, Dr. Rodriguez, Dr. White, Dr. Shin, and General Carden. Thank you for your commitment. You've been with us through a pandemic. I mean, who would have thought when you signed on to this board that all your work, Dr. Rodriguez, in maternal and infant mortality, would end up also underpinning some of the work that we were doing in COVID. So thank you very much, which leads me to say that even as we're continuing to work on COVID, and I recognize that we will probably never stop working on COVID. COVID will always be part of what we do in public health. We are now also pivoting to a lot of other things which are critically important, not just childhood immunizations, which we recognize not only the lifelong importance of them, but also that COVID itself paradoxically may have led to some vaccine questioning throughout the country. This isn't just a Georgia issue, it's a national issue. But also as we're pivoting to women's health issues throughout our state, as we're working to expand access to prenatal care and kind of getting back to some of our basics. I think this is all part of what we are trying to do simultaneously, even though for 2.5 years we were kind of focusing solely on COVID. Now we are having to learn to do that, but multitask with some of the old core public health activities, new public health activities, plus COVID. And you'll be hearing about some of those new public health activities, including monkeypox, in a minute. I do want to just mention briefly before we move on that, probably if you look at our numbers, the current vaccination rates are relatively low in new vaccinations, except for the youngest Georgians, because they just became eligible for vaccines. We still would like to get more of those youngsters vaccinated. But so many times I hear people say to me in just at the store, or not necessarily here in the public health setting, but as I meet them on the street, why should I get vaccinated? Why should I get boosted? I know people who are getting infected and they had all these boosters, they had all the vaccines. And I just want to remind everyone how, not only how important it is, but we don't see the increase in deaths. We don't see the increase in hospitalizations reciprocal to what we know are the number of cases increasing in the community. A colleague of mine at Carnegie Mellon in Pittsburgh was quoted today as saying, when your own social network becomes infected, that's when you know the community spread is really increasing. Well, my social network is certainly becoming infected with COVID, but at the same time, I recognize that they are also protected not only by boosters and vaccinations, but also by the access to antivirals. We have tools now that are really life-saving. And I just want to remind everyone about how important it is, and you as board members, to continue to repeat that message in the community, because we can't emphasize it enough. This is a critical time for us, particularly as we are pivoting to some of these other activities in public health that are absolutely essential to Georgia's health. So thank you in advance for your support for that. And I'll turn it over to Drs. Drensick and Dr. Millman.
Thank you. Dr. Dresnick, the floor is yours.
Thank you. Thanks, Dr. Toomey. Thank you, Dr. Rodriguez, and members of the board. It's a pleasure to be here with you again. In the short time that we have together, I just want to provide an update on two of the topics that we have briefly discussed before, COVID and our monkeypox EPI update as well. Can I have the next slide, please, Frederick? Yeah, thank you. As Dr. Toomey alluded to, and you've heard me say many times, our response to infectious diseases, it can be ever changing. They're very unpredictable, but we can be reassured that no matter what, having our pillars of accurate surveillance and epidemiologic investigation will always point us in the right direction to have the most efficient prevention and control recommendations to stop the spread of these infectious diseases. And again, this importance is illustrated time and time again, but I just want to highlight again our quick view of the landscape of COVID in its current form, and our monkeypox response here in Georgia. Both of these, again, very serious global outbreaks that impact all of us. Next slide, please. Okay, so let's just take a quick snapshot of COVID, kind of a tour like we usually do each month. And at this point, we really are seeing quite a large change than we did last month. So 4 weeks later, instead of, again, having the BA2 subvariant being dominant, now our COVID landscape is very much characterized by a single Omicron subvariant BA5. Now I'm calling it BA5 rising, and we probably can call it a BA5 wave very soon. So interestingly, though, as this Omicron subvariant has very quickly, again, risen in proportion and also outcompeted the BA2 subvariants, again, we're still seeing relatively flat case numbers. And Dr. Toomey mentioned this as well. This is both in Georgia and in the US. Again, this is probably, again, due to individuals either not being tested or using home tests. But we see this same sort of flat, plateau case numbers, both nationally and in Georgia. But now, really, even over just a period of weeks, this BA.5 subvariant has risen. As of yesterday, it was 58% of the total. And as a matter of fact, the new data just came out before this meeting from CDC, and BA.5 is up to about 65% of all circulating SARS-CoV-2 virus. So that's really remarkable in just a period of weeks. And that's because this BA.5 subvariant is much more transmissible and has really, again, an inherent increased ability to evade immunity, both from natural infection and also from earlier vaccine as well. So because of this, it's likely that we will experience future case increases as well as the SBA subvariant continues to spread. If you look nationally at kind of our hospitalization data, both nationally and here in Georgia, our hospitalizations are bumping up just a little, but our deaths are definitely decreasing as well. So again, the severe outcomes that we were seeing, sort of relative to case numbers earlier are not there. These boosters, and again, are still holding very well against severe outcomes. And I want to just highlight as well, even though with this BA.5 rising, just looking at the daily number of cases, is not always an accurate sort of view of what's going on. We're seeing increased community transmission. The magnitude of this wave is again, greater than the numbers show because of home testing and other factors. So no matter what, caution and prevention measures, even the traditional ones from the very beginning, are very prudent, but especially vaccination and boosting. And again, interestingly today, I'll just mention it briefly. I just heard about it. Again, the White House today really, again, came out with an announcement, kind of a warning, if you will, about the BA.5 rising. And again, the importance of us to, again, realize the pandemic is far from over. And also thinking about perhaps an upcoming strategy of actually offering second boosters to individuals that are younger than 50 years of age. I think that will be coming next, but we'll hear more about that as the days go on. So now let me just take a couple of slides and show you visually, how some of our surveillance numbers are looking. Can I have the next slide, please? So if you look at our case numbers, you can see over the last month or so, really they're increased a little bit, and this is by date of onset for individuals that, kind of like when they became symptomatic or when they became tested or ill. But again, we're really seeing kind of this as flattening over the last few weeks. Almost routinely, when you have a 4th of July holiday week in the midst of some of these surveillance numbers, things sort of flatten out. There's some reporting delays. But all in all, I just want you to kind of appreciate that we are really kind of seeing flat numbers that may belie, I think, really what's going on with these increases in BA.5 in our communities. Next slide, please. And if you look at hospitalizations here, this is really, as I show you each month, this is really the epi curve of the daily census of people that are hospitalized with COVID on any given day. And so if you look at the last few, 30 days or so, even, kind of from a month ago, we really are seeing some increases in hospitalizations, but a vast decrease since, sort of our previous Omicron peak. I think no matter what, even if we're starting to get, again, some individuals, the more people that are infected, we really are, we're still at low levels here. We're still seeing, when you think about percent changes, the more people that are infected, you still are going to have some people that end up in the hospital, but by far nowhere near what we saw in other waves. I think it's really also a very strong attestation to again, the importance of vaccines in regards to severe outcomes. Next slide, please. And our death numbers as well are actually, again, holding relatively steady, but also, kind of decreasing as well. We see, and this has been common throughout the pandemic, some reporting lags in regards to deaths, particularly from death certificates. This is not unique to us in Georgia. But again, overall, we're really starting to see, sort of our death numbers dip relative to where they have been over the last few weeks. So again, this is a positive, and I hope that this trend continues and also is related to vaccination as well. Next slide, please. And as has been true of all of the time that vaccines have been available, the reason, again, that we can show you and that severe outcomes such as hospitalizations and death are prevented by vaccine is really illustrated really well in these slides. Ultimately, we're looking at cases up in the upper right, hospitalizations in the lower left, and deaths in the lower right. And ultimately, if you look at the black lines, really are individuals that have had are unvaccinated or under-vaccinated. The red lines are individuals that have had a primary series only, and the gray lines are those that have had a booster dose, at least one or more. And as you can see, those gray lines really bring everything down really dramatically. And as you can see, even in the hospitalization category in this lower left-hand side, everything is still relatively low compared to other waves. But the impact of those boosters, those gray lines really are striking. And you've seen this before. And I think it really just kind of continues that message that Dr. Cheney mentioned earlier. Next slide. I just want to put kind of all three of those surveillance indicators together to kind of see where we are. So the red lines indicate, case numbers, the blue are hospitalizations, and the green line are deaths. So you can see even now, look at how low, some of our death numbers are, over the last month or so. And we are starting to see even, again, a little bit of bump in cases and our hospitalizations, maybe just a little bit as well. But overall, sort of the picture here is one less of, sort of like looking at the individual, sort of days and weeks, but look at it relative to the rest of the pandemic waves. And this particular graph actually begins when vaccines became available. So again, I think it's just further evidence that again, the impact of these vaccines is very strong. Next slide, please. So in summary, as far as, sort of our COVID landscape goes, certainly, as I mentioned earlier, the pandemic is far from over. There is no time for complacency now, even, kind of relative to months ago. It is still with us. It has proven very adept at changing. New variants emerge and has, myriad opportunity to do so. BA.5, has, again, the ability to continue to rise, considering its inherent abilities to evade immunity. And we should expect there to be not only sort of additional BA.5 increases and waves to come, but other variants that emerge as well. So what do we do? What do we do about this? Again, we have the tools, and again, we look at the surveillance and the epidemiology of COVID in this landscape really points that these traditional prevention measures are still really very, very important, and in addition to vaccination and boosters. And whether that expands in the future to individuals that are younger, or the development of vaccines, that contain other strains, that remains to be seen. But no matter what, even at this point, it's not a matter of waiting for that. It's a matter of getting boosted now and ensuring and reducing this risk to have any, severe outcomes from infections, and both from BA.5 and, not only if, but when other variants emerge as well over the years. So next slide, please. I'll stop there. Now we'll take a quick shift to the other global outbreak that's going on. And again, exploding really around the world, even in the last few weeks since we've been together. This monkeypox outbreak, again, monkeypox is certainly not a new disease. It was discovered in the late 1950s in Central and West Africa. We have a lot of experience with it, but not in this way. Traditionally, we've always seen, very rare travel-associated monkeypox cases in other countries from individuals that had been traveling to areas of West or Central Africa or had been in contact with animals there. But since May, since this outbreak was discovered, it really has exploded in a short period of time. The last time that we were together 4 weeks ago, the total number of cases of monkeypox globally at that time was 1,500, which I thought was tremendous then. We're up to 9,600 globally, just in a period of 4 weeks. And that is, again, most certainly an undercount. Again, there is, as outbreaks like this evolve and they're new, there's not as much widespread testing that's available, in many parts of the world and even here in the US. As we get testing expanded, we can capture more cases, but this is tremendous, and for us in the US, now we've seen very close to 900 cases in almost all states, 41 states. And I didn't write it on the slide, but I remember it when I updated the slide 4 weeks ago when I gave you this update. The number of monkeypox cases in the US was 49. So we've gone from 49 to 900 in this period of time. And here in Georgia, these numbers change, pretty rapidly by the day, but we're over 40 cases in Georgia today. And we'll probably have a few more even as the day goes on. So again, the current epidemiology, when you look at this monkeypox outbreak globally and here in the US and here in Georgia, is the same. And again, this is what drives our prevention strategies. But what we're looking at, a primary way the epidemiology, again, is manifest is person-to-person spread, in communities. Next slide, please. But again, it's not as if this is spreading person to person in ways like COVID or in ways like respiratory viruses. It really requires very close, direct physical contact. So let's take a look at the epi and the clinical picture, both in the US and Georgia. And then I think we will get an idea, and this hasn't changed from the last time we were together. We'll get an idea essentially of how we can target or better target our prevention measures in the context of having countermeasures or prevention measures that may not be as widely available as we would like or may like in the future. So what are we looking at? So we're looking at monkeypox in the US. We are seeing cases among adults. Vast majority identify as MSM. In Georgia, it's the same. And we really are seeing kind of the median age of our cases to be about 33 years of age, again, ranging from 23 to 57. We've seen, again, a variety of cases that have occurred, almost all from the metro area, the broad metro area in Atlanta. We're not seeing a lot of cases, at least yet, in other parts of Georgia or from rural areas. This may reflect some, testing, sort of what we call testing bias or surveillance bias. And again, among these it's a small number of cases in a way, but again, we're seeing a little over half are of Black race, 35% white. Most are of non-Hispanic ethnicity. The main risk factor that we're looking at is close physical contact with somebody that has had monkeypox lesions. Early on, as the outbreak was evolving and we were first hearing about it, many of our suspect cases reported travel, especially international travel, but recently most do not. So this suggests, not only here in Georgia, but around the US, that there is established community spread, likely in social networks. Many of our cases here in the US have co-infections with other sexually transmitted infections, traditional ones such as chlamydia, syphilis, herpes. But in this outbreak, kind of what is different clinically is also, I think, very telling and allows us to detect cases. And that's, the primary thing. We want to detect cases so that we can isolate them and do contact tracing and prevention. But again, in this outbreak, there's some notable clinical differences relative to what we've known monkeypox to look like for so many decades. And that it is really here, many of these individuals are not extremely sick. They're not presenting with a fever. They really don't have lymphadenopathy. And the number of lesions in the monkeypox rash is very minimal. Some of them have very few lesions or maybe even one or two. They often are located in the genital area, and they also can progress pretty rapidly through the stages of the rash. So it's just a little bit different. And I think probably early on when the outbreak first was evolving, likely, it could have been overlooked in some patients. It just doesn't look like what we knew monkeypox to look like in the past. But this allows us, again, to have a raised index of suspicion clinically so that individuals can get tested, isolated, and, the prevention strategies can be implemented. Next slide, please. So what does that look like for us? As I mentioned, one of the most important things for us is really to try to detect cases. Again, nationally, monkeypox has now been made nationally notifiable here in Georgia as well. That's just one surveillance tool. We rely upon clinicians, we rely upon our partners to have a raised, as I mentioned, awareness about monkeypox, about detection of cases, about testing cases, so that we can, as the primary way to respond to this from the public health standpoint, is the kind of tried and true measures that we use, not only for this, but you've heard all these words before, for COVID and many other, kind of communicable diseases as well. Identifying cases to isolate them, doing contact tracing, assessing risk amongst these contacts so that, again, the highest risk individuals that may have been exposed can be offered medical countermeasures if that's appropriate, monitoring them for development of symptoms, and really ensuring that again, during their potential incubation period, that there's not further spread. And you'll hear much more about the medical countermeasures from my colleague after me. But ultimately, for us in Epi, this is our mission, find them, isolate them, ensure that, again, we can stop spread moving forward. And that's how we've stopped and eradicated many, many, many other infectious disease outbreaks. So what we're looking at now, and I think is really, really key, is not only raising suspicion among clinicians and educating them, but trying to work federally and with other partners in ensuring that we have an adequate infrastructure for testing in our country. Not only we definitely have it through all of the public health laboratories. Our public health lab has been really the primary tester of all of these cases in Georgia, and are running, tests, groups of tests twice a day, if not more, all the time. But having the availability now for monkeypox testing in commercial labs will be important as we move forward in detecting cases. As we now have 2 commercial labs available for monkeypox testing, LabCorp and Mayo Clinic, but others are coming very fast. So probably by next week, we should have some other commercial labs up and running too. So ultimately, we want to ensure that for us in public health, we want to be able to, we've been in the role here in epidemiology of facilitating testing at our public health lab, but we really want to be sure that, again, clinicians are aware of calling us for consultation, but most importantly, knowing, to recognize the potential testing, whichever way is most efficient, knowing how to collect specimens, and advising case isolation, and for us in public health to follow up once we hear about it. So next slide, please. I really just wanted to draw your attention to, we have a page on our website really that ultimately just talks a little bit about, commercial testing options, how to collect specimens, how to advise cases about isolation, really just reference material for clinicians and for others to think about as they're considering diagnosis of monkeypox. And then just wanting to highlight for us, we in public health are available 24/7 at 1-866-PUB-HEALTH and can guide them through any of this. This is just, kind of backup reference for them. We have medical epidemiologists on call every day, all the time, monkeypox or not, but we're happy to help in that way. So next slide, please. And I think this is my final. I end as I started. No matter what we're facing, infectious diseases will always be ever changing and unpredictable. But we can utilize, and it's so important to have proper surveillance and epidemiologic investigation as the cornerstones of how we prevent and control. And in the case, for example, of monkeypox, where we don't have availability of widespread or of medical countermeasures to try to target them, to populations at risk or where they will be most effective. And my colleague, Dr. Millman, will talk more about that. I'm setting him up. And also my colleague, Nancy Neiden, will also talk about using epi for prevention and control recommendations as far as COVID vaccine as well. So I'll leave it to them to show you how this part is done. My part's the surveillance and epi. So thanks so much. I appreciate your time.
Thank you, Dr. Drenzik, as always, for your updates and your information. Any questions from the board for Dr. Drenzik? I have one, and it relates to the monkeypox, since it is associated with sexually transmitted disease. Is there a risk for potential transmission to a newborn? Do we know? Have cases been reported to this extent?
Thanks for the question, Dr. Rodriguez. And again, I think that I just want to clarify as well. I think the data, again, as far as transmission goes, is that it is not actually very well characterized that this is indeed a traditional sexually transmitted infection in the sense that we actually have virus in those in body fluids. However, it is more like this direct, close physical contact. So I do not think that we have seen that type of transmission. I mean, even in our experience, with monkeypox in other parts of the world. But I think that no matter what, we continue to learn more as we move along. But I want to be clear that it's more the physical direct contact to those lesions.
Okay. And with the BA.5, has there been any change in the demographics of the folks that are most at risk for hospitalization and death, or is it remains about the same, unvaccinated, immunocompromised, and an age is a factor?
Yes. So great question. And I'll just repeat that as well. So from what we've known so far, what our data has shown us, even over the last, for example, looking at over the last 30-day period, as BA.5 has been rising, we are still seeing hospitalizations and deaths primarily among individuals that are unvaccinated, and our individuals that are actually still dying of COVID, of their COVID infections are the vast majority of them are over 70 years of age and older. So yes, age and vaccination status, absolutely. Yeah.
Thank you. Appreciate that very much. Any other questions for Dr. Dresnick? Okay. Thank you. Thank you so much. Dr. Millman?
Before Dr. Millman comes on, this is Kathleen again. Mm-hmm. I just wanted to make note that I've been advised by my lawyer that we aren't allowed to approve minutes over email, so that the next minutes will be approved at the next board meeting.
Sounds great.
which we will convene in September. Given everybody's schedules, it looked like August was not going to work for everyone. So September will be the next meeting, at which time we can approve the minutes from last meeting and today.
Thank you for the clarification, Timmy. Appreciate that. Okay.
All right. Well, thank you, everybody. And thank you, Dr. Drenzik, for introducing the topic of where we are right now with monkeypox. So as was said, I'm going to be discussing some of the medical countermeasures that are available for monkeypox. So next slide, please. We'll start off by talking about vaccinations. So one key message here is that the use of vaccines is part of the strategy to control the outbreak of monkeypox, which is also referred to as MPV in different parts of the presentation. So we currently have there are two vaccines that are licensed by the Food and Drug Administration that are available for preventing monkeypox infection. One of them is called Jynneos, the other one is called ACAM 2000. Jynneos is for use in the prevention of smallpox or monkeypox in people 18 years and older. It can also be available for people younger than 18 years through an expanded access IND. ACAM 2000 is a vaccine that is for use against smallpox. It is allowed for use against monkeypox under an expanded access IND, which requires informed consent along with submission of additional forms. Next slide, please. So I put together this table because I want to just highlight the distinction between some of the vaccinations or between these two vaccinations, which underlies part of our vaccination strategy, which I'll be talking about a little bit later. So when we look at the comparison of the two different vaccinations, so the Jynneos vaccine is a replication deficient modified vaccinia ankara virus, whereas ACAM 2000 is a replication competent vaccinia virus. So basically what this means is they're both live virus vaccines, but the mechanism by which it functions is a little different, whereas with ACAM 2000, you actually will have you'll actually have a vaccine pox mark that will come up and that will fall off. Whereas with the Jynneos vaccine, because it is a replication deficient virus, that does not happen. In terms of the administration, Jynneos is administered subcutaneously in 2 doses, 28 days apart, whereas ACAM 2000 is administered percutaneously by multiple puncture technique in a single dose. The next difference is about take, and I had alluded to this before. So for Jynneos, because it is a replication deficient virus, you do not see any take after the vaccine. It's similar to other vaccines where you get the vaccine, your arm might hurt for a little bit afterwards, but it heals, there's no mark afterwards. ACAM 2000, on the other hand, because it is a replication competent virus, you actually get a lesion it's like at the site of vaccination. And that is seen if it has successfully been administered. That lesion will then scab over and fall off, leaving a scar where the vaccine had been administered. And that is referred to as take. And during that period of time, it may take up to 6 weeks. An individual potentially has the risk of auto-inoculation, where if they touch the lesion with their hand and touch their eye, touch their skin, they could actually spread virus and spread lesions to other parts of their body. Or if they come into contact with other individuals, they potentially could actually spread potentially spread to other individuals. With Jynneos, because it's a replication deficient virus, that does not happen. Additionally, for cardiac adverse events, Jynneos is considered quite safe, whereas ACAM 2000 has had reports from the clinical trials of myocarditis and pericarditis that have happened fairly frequently in adults who receive vaccination for the first time. For other contraindications, the Jynneos vaccine can be given to many different populations, including those with immunocompromise and including those with HIV. The real contraindications for it are people who have an allergy to a vaccine component. Whereas, as you can see, ACAM 2000 has multiple contraindications for different disease states, including HIV, immunocompromise, people with atopic dermatitis and eczema, and cardiac disease. Finally, just in terms of the effectiveness, I've said that it's unknown in the current outbreak, and that's just because we do not have data on the use of these vaccines in the current outbreak. Jynneos has been used for responding to monkeypox outbreaks in the Democratic Republic of Congo, as well as in recent outbreaks of monkeypox in the United Kingdom prior to the current outbreak. And those have shown that they were actually very successful at being able to reduce transmission of monkeypox in those settings. Next slide, please. So I just want to highlight again some specific considerations for ACAM that are very important. So I had mentioned the adverse events following ACAM 2000 could include myopericarditis, as well as this issue about take, where you can actually transmit the virus to other household contacts. And in some cases, those can be quite serious. Additionally, if you're thinking about using ACAM 2000 in a vaccine setting, anybody who is offered ACAM 2000 needs to be tested for HIV prior to vaccination to ensure that they're HIV negative, because HIV is a contraindication to receiving this vaccine product. Additionally, recipients need to keep the vaccination site covered and avoid activities such as swimming, sharing blankets and towels, contact with people who might be at risk for serious adverse events, such as those with weakened immune system, individuals who are pregnant, children younger than 12 months, while you're waiting for the scar to heal and for the scab to come off. And providers need to also advise the vaccine recipients on how to keep the vaccination site clean and covered until the lesion completely heals, which can be up to 6 weeks. Next slide, please. So for other vaccine considerations that we have, just a couple things. So people who receive Jynneos are considered to reach maximum immunity 14 days after their second dose. So that would be 6 weeks after the first dose of vaccine product. Whereas people who receive ACAM 2000 are considered to reach maximum immunity after take has occurred, which is about 1 month to 6 weeks. But until that full immunity is reached, specific precautions need to be taken to prevent the spread of virus to others. Additionally, since there's really no current data that's available on the effectiveness of Jynneos or ACAM 2000 from the current outbreak, CDC is still recommending that people continue to take steps to protect themselves from infection even after vaccination has taken full effect. So I just bring up all of these differences for the two different vaccinations because there's a lot of considerations that are there. But given the safety profile of Jynneos, the fact that it can be given to a larger population of individuals who potentially could be at risk, right now the underlying strategy for Georgia's vaccination involves giving Jynneos vaccination to populations who are at risk. And I'll provide a little bit more information on what we're doing next. Next slide, please. So for vaccine supply, as part of an effort to control monkeypox in the United States, the federal government has allocated the limited supply of the Jynneos vaccine to jurisdictions with a phased approach. So HHS has made 296,000 doses of Jynneos available in phase 1 and phase 2A allocations. I've put the phase 1 and phase 2A allocation numbers for Georgia in the bullets below. Phase 2A allocation became available for ordering yesterday on July 11th. And one of the challenges that we're trying to face with the very limited supply of allocations that we have been given is that the first and second doses need to be managed from these allocations. So even though the numbers might look larger, you have to account for the fact that there are second doses that are going to need to be given to individuals during this period of time. HHS anticipates that 750,000 doses of Jynneos will be available over the summer, but the exact timing of that availability is unknown. Next slide, please. So just in terms of our vaccine availability, so DPH must request all vaccine from the Strategic National Stockpile. Health departments right now are using contact tracing to identify contacts of monkeypox cases to assess the type of exposure, risk category that they've had, and also the timing of the last contact to help determine eligibility for vaccination. And for any vaccine requests that are happening right now must be coordinated through health departments. But given the currently limited available supply, vaccine is being prioritized for specific indications. Next slide, please. So those specific indications are here. Our current priorities, given our limited supply, include post-exposure prophylaxis, or PEP, and that is for people who have had a high-risk exposure to a confirmed monkeypox case. And PEP is something that is most beneficial when it is within 4 days, when it's given within 4 days of exposure, but there may be some benefit up to 14 days following the exposure. The other priority group that we have right now are those who would be eligible for expanded post-exposure prophylaxis, which is referred to as PEP++. And this is for people with certain risk factors that might make them likely to have had high-risk exposure to monkeypox. So somebody who potentially was in a setting where monkeypox may have been spreading, where it's possible that there could be people with certain risk factors that would be present, and those individuals would be the ones that you would prioritize for PEP++. And this is used for response to outbreaks in areas where monkeypox spread is occurring. Next slide, please. I just wanted to highlight the final other category that we have, which is vaccine pre-exposure prophylaxis, also known as PrEP. So this is indicated for people with certain occupations that may place them at high risk for potential monkeypox exposure, such as laboratory staff working with monkeypox specimens. Due to the limited vaccination supply that we have right now, vaccine is really being prioritized for the purposes of PEP and PEP++ at this time, as that's really going to be critical to being able to control the outbreak and to stop the spread. So laboratorians should use appropriate BSL precautions when working with specimens that are sent for monkeypox evaluation, as that's really going to be the thing that will be able to protect them best. And then for healthcare providers, they should be using standard and recommended isolation precautions when caring for patients with suspected or confirmed monkeypox. Next slide, please. So just to summarize some of the activities that we're trying to prioritize right now, we are coordinating with our epidemiology colleagues and public health districts to ensure that PEP is offered to eligible individuals. We are also coordinating with our public health districts to conduct community vaccination events for PEP++ for populations that may have more likelihood to have exposure to monkeypox cases. We are also trying to identify opportunities to vaccinate at-risk individuals for whom ACAM 2000 would be contraindicated. And finally, we are also trying to respond to any changes in outbreak epidemiology that may require us to reevaluate vaccination priorities in the context of the currently limited vaccine supply. Next slide, please. So for the final topic I just wanted to mention is just a shift away from vaccinations and to talk about treatment options for people. So most people with monkeypox have a self-limited disease course, and they will recover in 2 to 4 weeks without the need for a monkeypox-specific treatment. However, treatments may be considered for some people, such as those with immunocompromising conditions. There is an antiviral drug, tecovirimat, also known as TPOXX, which was developed to fight smallpox, but the FDA allows its use to treat monkeypox during the current outbreak. The effectiveness of this drug in treating monkeypox is unknown, but animal studies have shown it to be effective in treating disease caused by other orthopox viruses. So if there is a case in which a clinician is considering using tecovirimat, they should consult with the health department, since the health department can advise, can help work with the clinician as well as with CDC to determine whether or not this may be beneficial for that patient, and to help coordinate the release of the medication from the strategic national stockpile. Next slide, please. So I know I presented a lot. I would be happy to take any questions on where we are right now.
Thank you, Dr. Milne. That was a lot of information. Any questions from the board for Dr. Milne? Just to reiterate, because you made a comment that with the current process, you're going to be looking at those that do not qualify for ACAM 2000, I think it's called, ACAM 2000, I'm sorry. Does that mean that we're going to have ACAM 2000 available in Georgia or not? Because you mentioned that we also made the decision to go with Jynneos as the vaccination protocol.
So at this time, the vaccination that we are using in Georgia is Jynneos, and that's because the favorable safety profile. And as I had mentioned in terms of ACAM 2000, there are a lot of safety considerations that need to be considered, and there's also a lot of logistical issues that need to be considered in terms of how the vaccine would be able to be delivered. So, in the current setting where we have an available product that is safe and beneficial, we want to be able to prioritize the use of that product right now.
Good. Thank you. Appreciate that. Any other questions for Dr. Millman? Thank you for your presentation, sir.
Thank you.
We'll move on with Nancy. I think you're going to give us some information on the communications for COVID-19.
I am. Thanks, Dr. Rodriguez. As Sherry mentioned, I'm going to bring us back full circle to COVID and vaccine and boosters. We are launching, as we speak, a new statewide campaign. If you haven't seen it yet, you'll start seeing it soon, I hope. The campaign is It's That Simple. Frederick, can you advance the slide? We're going after a public, COVID-weary public by not telling them what to do, but reminding them of some of the things that they've missed the last 2 years. And we're relying heavily on images that remind people of all those things, and saying that those are possible again in large part now due to COVID vaccine boosters. The campaign, as you can see, includes billboards, buses, bus shelters, social media channels. We've got digital and mobile, along with print, radio, and TV. So I'd like to share with you the new spot that will begin airing on TV. Frederick, if you can play that.
It's been a long time coming. Reuniting with family members we haven't seen for too long. Gathering with friends we have missed so much. Taking those trips with our families that are long overdue. Yes, Georgia, we can be together again. We can have that barbecue. Go to those concerts. Enjoy a festival. Catch a few ball games. And yeah, host those big parties. Let's not lose another minute of precious time. Let's celebrate with peace of mind. COVID-19 vaccine and booster. It's that simple.
So that's one spot. We have a second spot that has a different voice on it. If you think that the woman's voice sounds familiar, because when she's not doing COVID vaccine and boosters, she's advertising for Wayfair.com. It's sort of startling every time I have the TV on and I suddenly hear her voice talking about something other than COVID. We'll be moving on to focus more closely on vaccinations for children, especially young children. We're in the process of creating a series of Ask the Expert videos that have a number of pediatricians, including Dr. Cheek, who just finished her recording, I think, last week. And we're extremely grateful, Dr. Cheek, for your doing that with us. We also have two other videos that are in the works. You may remember last year we did a video with Blake Bargatz. He was the young man, 24 years old, who wasn't eligible for vaccine yet. And he contracted COVID, ended up in the hospital for between 4 to 5 months and with a double lung transplant. Well, Blake is doing really, really well. He had a double lung transplant at the University of Maryland, but he is back in Georgia full time now. He's back to work. And he was really excited about doing a follow-up video with us to, again, promote vaccination, to say, no, nobody needs to go through this like I did. So learn from me. And on a separate note, he and his mom were just so grateful for the care, but mostly for the fact that somebody donated lungs. And so we are doing a separate spot with him and his mom that will promote organ donation. So we have gotten some great stories from people that have been so willing to share with us, and that's what we're going on. So look for the It's That Simple campaign and all the other things we've got in the works.
Excellent. Thank you, Nancy. Any questions for Nancy regarding the campaign and the direction that's taken, which I think is a fantastic idea, basically focus on things that you're missing and focus on things that you can get back to doing rather than being somewhat penalizing on folks who are not doing it. So it's great concept. Thank you. Okay. Hearing no questions, and Dr. Timmy, if you have any closing remarks for the group?
Yeah, just to say that between now and September, because it seems like it's a long way off, if there are issues or questions or any ideas you have, please reach out to me. We can either respond immediately or put together some additional information to get out to you. Things happen fast. Just thinking that monkeypox was not part of our vernacular just a few months ago, and now it is. But as things come up, please let me know, and we can get the additional information out to you. And if there's some specific things you would like us to talk about in September, we can ensure to put them on the agenda for the next meeting. But as always, thank you for your support. Public health is full of surprises, and as you well know, and we really so value your input and all that you've done to help us get through the last almost 3 years.
Thank you. Thank you very much. Any questions or comments from any of the board members that are on? If not, then if we can get a motion for conclusion of this meeting.
Motion to adjourn, Dr. Sheik.
Thank you, Dr. Cheek. Appreciate it. Appreciate everyone's time, and I hope everyone has a great rest of the summer, and we'll see you back at September 13th for our next meeting. Have a great afternoon. Thank you.
Thank you.